So welcome everyone to our special World Pneumonia Day webinar, Climate Change and Respiratory Health. My name is Leith Greenslade and I'm coordinator of the Every Breath Counts Coalition. I'm delighted to moderate today. So today is World Pneumonia Day, the 12th of November, but it's also the second day of COP29, the big climate conference happening for the next few weeks in Azerbaijan this year. So we thought it would be a very good idea to talk about climate change's impact on pneumonia or respiratory health generally. This is something we have not talked about enough. We need to get serious about this. As you all know, pneumonia is the leading infectious killer of humans, 2.2 million deaths in 2021, according to the Global Burden of Disease. What you may not know is the leading risk factor for those deaths across all ages is air pollution. Household air pollution is a little over half, and then outdoor as well, both leading risk factors. But guess which one is rising dramatically? The outdoor air pollution. And there's another risk factor rocketing up the list for pneumonia death, high temperatures. So here to talk about all of that and more, we have four leading experts. You'll hear from Heather Adair Rouhani from the World Health Organization, Rebecca Nantanda from Makerere Lung Institute, Uganda, Laura Jane Smith. She wears many hats, but she's going to present today a really important piece of policy from the British Thoracic Society, and John Sampson from Johns Hopkins University. Each speaker will have 15 minutes to present their case, if you like. If you can hold your questions until the end, we've built in a lot of time for what we hope is a very robust debate. So feel free throughout to put your questions, comments into the chat, but you will have a lot of time at the end of the session to really converse. We're recording today and we will be sharing this recording widely. And we ask you to post some of the things you learned today using hashtag World Pneumonia Day and hashtag COP29, because we really want to knit together these two really important issues, climate change and respiratory health. I'm going to stop sharing my screen and hand over to our first speaker from WHO, Heather. Heather, are you with us? Heather may be having difficulties dialing in, so we'll move to our second speaker, Rebecca Nantanda. Go ahead, Rebecca, while we try and find Heather.
Thank you, Lee, for the introduction. Let me share my screen. Thank you for the opportunity to be part of these conversations. I'm going to talk about outdoor air pollution and chronic respiratory conditions, sharing some evidence from Africa. My name is Rebecca Nantand. I'm a pediatrician and also a senior research scientist, and I work with Makerere University Lung Institute in Uganda. I want to start off by emphasizing the fact that worldwide, 8 out of the 10 countries with the highest PM2.5 exposure in Africa. PM2.5 is particulate matter with a diameter of 2.5 micrograms per meter cubed, but and it's the most measured particulate or air pollutant that we know of. So if you look at this map, the darker the shade of blue is, the more polluted the country is. So you'll find that most of the countries that actually have high exposure to PM2.5 are in Africa. And then when we look at the common sources of ambient air pollution, also known as outdoor air pollution, particularly for Africa, we see that there are quite many. We have a lot of crowded cities that are highly polluted with a lot of traffic congestion, a lot of construction work going on. We have industries that are coming up because Africa is rapidly urbanizing. So we have a number of industries that are coming up. We have a lot of burning of waste, open burning of waste. So waste management is an important contributor to air pollution in Africa. The unpaved roads, we have a lot of these trucks on unpaved roads, both in the cities and the rural settings, that also generate a lot of dust, and therefore part of it is PM2.5. And I want to mention the fact that in Africa, there is quite a bit of roadside cooking for kind of commercial activities, many times we tend to ignore this and maybe put it as part of household air pollution. But in urban settings, there is actually a thin line between household air pollution and ambient pollution. And this is a big contributing factor in cities in Africa. I want to share some of this evidence. This is work that was done in Uganda. So they measured 2.5 ambient PM 2.5 within the city. And the message I want to bring from here that if you look at the daily variation between Monday up to Sunday, for all the areas where PM 2.5 was measured, all of them actually it was above the average allowable by WHO 15 micrograms per meter cubed. So you find that all the areas in Kampala in the city actually on all the days, they're actually highly polluted, meaning that the people who are living in these cities are at high risk of all the diseases that are really where air pollution is a risk factor. And I want to share another piece of evidence. So we did this study where we measured air pollution exposures in children. This study took part in 6 countries in Africa as part of the Acacia study. So in this Acacia study, we're looking at prevalence of asthma and asthma control in children. So we went ahead to measure air pollution exposures among children going to school for 5 days. So they had to wear these backpacks that you see where the air quality monitoring equipment was. We're able to find out the exposures when they're at home, during the transit to school, and while at school. So when we look at the key results that only 20% of the 11,900 days of monitoring were those days when PM 2.5 was actually lower than the WHO recommended, meaning that 80% of the time, regardless of where you're at home, on your way to school or at school, the amount of PM 2.5 the child was exposed to was way higher than what is recommended by WHO. And if you look at the mean daily PM 2.5, it varied between the different countries, but generally it was between 16.0 and 41.8 when we are looking at the mean daily PM 2.5. But what is very important when we are looking at interventions, when we looked at the characterization of the exposures in the different environments, we find that children are exposed both at home, in transit, but also at school, but this varied from country to country. And this means that when we are trying to intervene, we should first of all look at the environments where children are exposed to air pollution, but also context is very important because many times we have intervened at home and not at school, and yet many times children actually spend most of their time at school. So when we are looking at interventions to prevent chronic respiratory disease, we have to look at the different environments where actually people get exposed to high levels of air pollution. So this report came out this year, the state of global air, and it clearly indicated that currently air pollution is the second largest risk factor for deaths as of 2021, contributing a total of 8.2 million deaths globally. But I want to point to the fact that 53% of these deaths are actually due to ambient air pollution. And this speaks to what Liz just mentioned, that there is a rising number of deaths contributed to by ambient air pollution. And this becomes very important, especially for Africa, because like I mentioned, we have rapid urbanization, we have high population moving from rural to urban settings characterized by new buildings, roads, many cars, and that are not yet meeting the really standards of emissions that we are looking at. And then the other thing that I wanted to mention, if you look at this 58% of the deaths due to ambient air pollution, again, majority of them are in South Asia and Africa, where really the highest burden of disease is. And indeed, this report clearly shows that populations from low and middle income countries are exposed to 1.3 to 4 times higher levels of ambient PM 2.5. And this means that really, when you look at people from Africa, we're at high risk of developing chronic respiratory diseases as a result of being chronically exposed to high levels of air pollution. And this includes where we have poor lung function, especially in children. And we have research that clearly shows that when your mother is exposed to high levels of air pollution during pregnancy, you are born with poor lung function, and this exposes you to high risk of diseases like asthma, chronic obstructive pulmonary disease, And I also want to mention on this World Pneumonia Day that up to 50% of the pneumonia deaths can be attributable to really ambient air pollution for these children. Another piece of evidence I want to share very quickly is the work that we did in Uganda. So we looked at data from the health management record system, looking at the diagnosis, and we also monitored the air pollution, particularly PM 2.5, and wanted to compare whether there were more admissions and hospital visits during those moments when we had high levels of PM 2.5. And what we found that for asthma as well as pneumonia, the healthcare visits were many more and significantly many more on the days when the PM 2.5 levels were higher compared to the days when PM 2.5 was low. And this gives us really another piece of evidence where it is clear that acute exposure to high levels of air pollution can actually lead to hospitalization and emergency visits. And this evidence is already generated even in countries, in high-income countries. So again, reduction of exposure to ambient air pollution is going to be critical if we are to reduce the hospital visits and the associated high healthcare costs. Looking at ambient air pollution and child health. So another study that we did was among school children again. So this study comprised children who are in a rural setting as well as the children from urban settings. We monitored PM 2.5 in these schools, and we also measured the lung function and the prevalence of respiratory symptoms in these children. And what we found was that children in sites where there was high ambient air pollution exposure had lower lung function compared to those who were in lower ambient pollution exposure. And according to the lung function measurements that we did, when you looked at the forced expiratory volume and forced vital capacity, which are measures of lung function, it was poorer in those children who were from areas that were exposed to high levels of ambient air pollution. And this means that these children are actually at high risk of developing chronic respiratory diseases like asthma and COPD later in adulthood, in addition to suffering repeated attacks of respiratory diseases and symptoms. And another piece of evidence, which again, which we looked at the air quality management strategies in Africa. So this is the work we did with colleagues looking at ambient air pollution as well as household air pollution, and wanted to find out in Africa, what are those strategies that have been put in place to try and reduce the ambient air pollution as well as household air pollution? How best or how effective have these interventions been, to try and figure out what we need to do to actually reduce exposure or even generation of the air pollutants in regarding ambient air pollution. So what we found is that in Africa, only 17% of the interventions actually focused on ambient air pollution, despite the fact that there is evidence that it's becoming more and more problematic, especially in Africa. And that means that to date, a lot of attention has been given to household air pollution, which is not a bad thing, but we need to really proactively also look at interventions that can help us reduce ambient air pollution. Now, in Africa, like I mentioned, there is a lot of urbanization, so we are having a lot of traffic. We have a lot of second-hand vehicles, and these give rise to really a lot of emissions. So when we analyzed in this scoping review, we found out that mobility strategies comprise only 6%, despite the high burden of traffic-related air pollution in Africa. Again, looking at context when we are really designing these interventions is going to be very critical, looking at what has the most common sources of air pollution, and therefore design interventions that can drastically reduce the air pollutants from those sources of air pollution. And then what was very critical that for most of the interventions, there was no assessment of the health impacts. And we think this is really a very big mixed opportunity, because whatever we are doing now, we are looking at air pollution and health. And so for us to find out if these interventions are really effective, we need to be able to measure the health impacts in the different populations. And that information can also be extremely helpful when we are trying to create awareness, because we would then have granular data to provide the evidence that these interventions work. And so the other thing that we found is really that there is a lack of data around ambient air pollution and respiratory health in Africa. And I just want to share this map. This was a systematic review looking at the different studies regarding ambient air pollution and respiratory health. And as you can see, there were just a few studies in West Africa and Southern Africa, and none really in Central and East Africa, as well as Northern Africa. And this means that we really need to improve in trying to find out what are the ambient air pollution levels in the different settings, what are the health impacts, to be able to again come to interventions that are going to help us to reduce the air pollution exposures. And so what I'm trying to say here is that we need to have studies that are going to help us understand the short-term and long-term health impacts of ambient air pollution. But very important as well is to evaluate the economic and psychosocial burden. These are really usually hidden impacts. We focus on the reduction in air pollution levels. We also focus on the health impacts, but many times we don't measure the economic and psychosocial impacts. And these are very, very important. So for us to be able to really create or design interventions that are comprehensive and therefore lead to significant impact, we need to have this comprehensive understanding of the ambient air pollution associated respiratory health burden. And then lastly, in terms of research gaps, we need to find interventions that are effective, that are scalable, they are sustainable, and in context, because like I mentioned, different contexts are important when trying to design the air pollution interventions. And these air pollution interventions have to be a package of those at policy level, at technological level, as well as really health education to try and provide a comprehensive package to address the problem ambient air pollution. So this is what I think we need to do, or we need to act now. Number one, the reason why I think we need to act now as soon as yesterday, Africa's population living in urban areas increased from 15% in 1960 to more than 40% by 2020. And it's predicted that by 2050, it will be about 60%. So with all the challenges of urbanization and ambient air pollution, we really need to act now to see or to develop interventions that can mitigate the problem of ambient air pollution. And then statistics shows that cities such as Kinshasa in DRC and Lagos in Nigeria will actually be among the largest cities in the world. So as we have this urbanization going on and the cities expanding, we need to put in place mechanisms that will mitigate the problem of ambient air pollution and therefore reduce the risk of respiratory diseases, as well as other diseases that are actually from exposure to air pollution. And then for now, we know that emissions of air pollutants from fossil fuel use are expected to increase twofold in Africa by 2030. So we are at such a stage where we are still using a lot of fossil fuel. And so we need to find mechanisms of really trying to see that we gradually reduce this. It's a reality for Africa that we may not change overnight, but we need to have interventions that will help us as we develop, as we expand our cities, to make sure that we reduce gradually the use of fossil fuel and therefore reduce the risk of ambient air pollution. And then another key prediction for Africa, which we need to put into considerations as we design interventions, as we act, is that the incidence of respiratory conditions and respiratory-related mortality is also expected to increase, again, because of urbanization and climate change. And I want to end here by really providing some insights around air pollution and climate change in the African context. We know that urbanization combined with climate change will really be among the greatest challenges to development in Africa. Africa is trying to develop, but with these factors in play, it's going to be very difficult. It's likely to take us backwards several years. Again, looking at air pollution and heat, these are key factors when you're looking at the African context. They're interlinked. It's clear from science that the interaction between air pollution and heat actually has very negative effects on the respiratory system. And therefore, we need to find ways of really tackling these key big things for Africa, because we know that particularly for people with chronic respiratory diseases, they become highly vulnerable and have low adaptability to these key climate factors, and therefore at risk of really worsening disease, or even those who have not yet developed to actually develop the disease. So we need urgent needs. There is urgent need to prevent and mitigate and have mitigation strategies reduce the incidence of the associated CRDs due to these two climatic factors. And very important for us is that we really need to find ways, or we need funders to come strongly to help us to do research in trying to see which interventions we need to do to prevent exposure to ambient air pollution or even generation. But very important is that we need a lot of awareness. One of the challenges we find is that people are not very aware about the health impacts of ambient air pollution. They usually relate it to tree cutting and other things, and the health impacts are not very clear or very obvious to them. So we need to create a lot of awareness about the problem of ambient air pollution and respiratory health. I want to end with this slide saying that we need to create a lot of public awareness. I've done my part and continue to do, and I want people here to really join me in creating and increasing awareness about ambient air pollution and its impact on human health. Thank you so much for listening to me.
Thank you. That was Rebecca Nantanda from Makerere Lung Institute in Uganda, a world leader on understanding air pollution and respiratory health. Rebecca, you said a lot of things that have caught the attention of this audience. They put some questions in the chat. Take a look at them, but we'll pick them up in the Q&A. And I know you shared a lot of data, a lot of publications. We'll try and make sure everyone gets those as well. So thank you so much. I'm delighted to say we are joined now by Heather Adair Rouhani from the World Health Organization. You can imagine how busy she is this week with COP29, but she has spared some time to talk to us. We're extremely grateful. Heather leads air quality, climate change, air quality, and energy. What a portfolio with the World Health Organization. So we're waiting with anticipation into what she will tell us about what we need to do to reduce the health impacts of climate change, air quality, and energy. Heather, over to you.
Thank you so much. And again, thank you so much for that introduction, Lee, and I apologize for the delay. Indeed, we are actually working ourselves at the moment to make sure that we can get some global commitments in regards to air pollution. So we are planning a big conference with the government of Colombia for March. So let me go ahead and get started with my presentation. Can you all see this okay?
Perfectly.
Perfect, great, okay. So again, thank you for the kind introduction. My name is Heather Adair Rouhani, and I'm the Acting Unit Head for Air Quality, Energy and Health unit here at WHO headquarters in Geneva. So I'm going to kind of give you an overview picture, I would say, of the air pollution picture. And I was just listening to the final remarks of the previous speaker. And indeed, it's an important issue in Africa, but it is an important issue globally. And we are something we really have to challenge and achieve together as a group. It's a collective problem for collective action. So indeed, the most commonly heard number is the 7 million deaths. So WHO estimates around 7 million deaths a year are attributed to the joint effects of household and ambient air pollution. And in many cases, in a large fraction of these diseases, in fact, are due to pneumonia, which is often related to the lack of lungs having difficulty getting oxygen, et cetera. So we're really aiming to drive ambition and commitments to achieving this, because 7 million deaths is a tragedy and should not be happening each year. The diseases we see most exposed, that we calculate, there are many different diseases that are associated with air pollution, and the epidemiological evidence is growing stronger each and every day for recent action. But there are some certain diseases for which we have very strong evidence. And so those specifically are stroke, ischemic heart disease, lung cancer, chronic obstructive pulmonary disease, and pneumonia, and as well as asthma, but we don't count deaths from those. But those are the diseases for which we have the strongest evidence. However, air pollution, of course, is also linked to adverse pregnancy outcomes like low birth weight. We're seeing perhaps correlations with cognitive development in children, the idea of actually contribution, potentially emerging evidence suggesting connections between dementia and air pollution exposure. So really, from the second you breathe, or even in the child's womb, in the womb of the mother, the child being exposed to air pollution is really setting out a life impacts. And so we really need to start and to clean up the air now for the future of the children and the people we have now and in the future. So again, this is highlighting, again, some of the key figures that we have at WHO. The 7 million number, as I alluded to earlier, that comes to around 9 out of 10 people, globally speaking, air that is technically not safe by WHO's air quality guideline levels. And then we have the further issue that 2.3 billion people this year are still lacking access to clean cooking in the home, which leads to a large amount of household air pollution and pneumonia deaths, as well as ambient air pollution and those associated deaths. And this just comes under a larger umbrella of around 1/4 of deaths are due to environmental risks. And you can see down here on the bottom figure, those are pictures of lungs. These are not lungs of smokers. These are lungs of people that have never smoked, but have grown up in very polluted environments. And this shows you that people breathing in air pollution is really a source of ill health and impacting the body. And in a sense, again, air pollution itself impacts all throughout the body. So very fine particles are able to penetrate across the barriers of the lungs and impact the body systemically, leading to a variety of diseases alluded to here. Some are highlighting here: respiratory diseases, cardiovascular diseases, neurodevelopment diseases, pregnancy outcomes, etc. So it really impacts the body systemically, and hence tackling air pollution right as soon as possible really can help prevent diseases and really ensure healthier lives for all. Now, to highlight this is the focus of this idea of the importance of children and this every breath counts oxygen aspect. So there's particular aspects of air pollution that impact children in a special way. Children are lower to the ground. They have different physiological mechanisms. So when they're breathing in polluted air, it can really hit hard on the body and lead to disease and adverse health outcomes very early on. Particularly respiratory infections are the first things we see with pneumonia, as well as the onset of asthma, etc. But it also sets up and impacts the body for other non-communicable diseases elsewhere later throughout the life course. So really trying to clean up the air and reducing exposure in children early on is really key to make sure that we build the strong, healthy bodies of our future generations. And this is again highlighting just some of the child aspect of this. This is our recent statistics from 2019. Quick call out that we'll have new updates from the WHO statistics in the beginning of the new year. So please stay tuned for that. But our most recent statistics show around 1.1 million premature deaths are associated with respiratory infections from exposure to air pollution, both in children and adults. And you can see from this graph, this is just some of the age groups. So it gets to about 500,000 of those deaths, just a little bit less, are actually among children under 15 years of old. The gray here is under 5 alone, showing the importance of the first year of life and this exposure to air pollution. But you can see even as the adolescence years, we're still seeing a large amount of ill health associated with exposure in children that are a bit older children, as well as adults. Now, the problem is air pollution is everyone's problem, but nobody's problem all the same. And there's a lot of finger pointing. And so we are trying to really to highlight the important linkages that air pollution has in terms to climate change as well. So taking action actually on air pollution is a way to mitigate climate change and protect people from the health effects of climate change in and of itself. So here, this is just a comparison. You can see that many of the same sources of ambient air pollution are those same sources of buildings, presenting us an opportunity to really leverage all the actions on climate change that are ongoing and the investments and the finance going around climate change to tackle air pollution hand in hand. This is a big, just to flag. So WHO has recognized air pollution as an important source of ill health for a number of years or decades, let's be clear. Our first report came back out in 1958 around air pollution and health linkages. And so WHO has taken this on and really sees the health sector as having a key role to play in tackling air pollution and really driving this primary healthcare approach and driving these root causes of air pollution, whether that's working with different sectors or making sure that the actual individual is protected. Accordingly, we've published guidelines that are used to help national air quality standard development. as well as we've had various advocacy issues, activities, etc. So, for example, we had the first air pollution conference back in 2018 with over 900 participants, and we are just planning the second one, and that was alluding to earlier, that will take place in March at the end of March 2025, at the end of the month. Will be our second global conference in Colombia, Cartagena. And we're really trying to drive commitments from different stakeholders at country and city level, civil society organizations, research community, health professionals, to really agree on actions and commit to actions to tackling clean air to protect health. And this is, but this is just the one stop on a long road that we hope that this community on this call, this webinar here, can engage with and support along with other actors throughout the globe, essentially. So as I mentioned, WHO produces WHO air quality guidelines. So these are really important evidence, synthesis of the evidence. They typically take 45 years of deep dive conversations and systematic reviews and meta-analysis with some of the top world experts on air pollution health. And they're really important levers to putting together air quality standards in countries that can ensure that health protection goes through. It provides health-based recommendations for a variety of pollutants. The levels of pollutants that are safe can be considered for health. And this can help drive actually action in other sectors as well, for them to be able to link what emissions are coming with actually health-based risks. In addition to these guidelines, because getting to the guideline value is a very difficult challenge. The current value for example, for fine particulate matter is 5 micrograms per meter cubed. Many places of the world, this is way, way difficult to achieve. And where there has, in some cases, 10, 20 times, 30 times the actual air quality level, guideline level is what people are exposed to. Hence, WHO has set up a set of interim targets to help countries to actually take a stepwise approach to achieving health protection and achieving the actual guideline values. So we've created these interim targets to help countries get to take the steps, the pathway to actually achieving clean air. I'm not going to go into detail about this, but this is just a big summary of what these guidelines say, basically providing specific values for different pollutants, averaging time. So we have values for actually a 24-hour period, but also over the year. And we also provide good practice recommendations to help really push some agendas for which we don't necessarily have the greatest degree of evidence, but we have a strong reason to push further evidence, such as black carbon, ultrafine particles, sand and desert dust, etc. Now, how close are countries actually to achieving these? They're not so close, let's be honest. We have very few countries, I think maybe one, that actually achieves the guideline level, whereas most countries have quite a bit further way to go. So we're really trying as WHO to provide the tools for the health sector, as well as other sectors, to use health impact assessment, to define policies, sectoral policies that will protect health, giving the voice of the health sector, providing that education and capacity building materials to health professionals to speak to the clinic and the community and to the politicians about what's the importance of air pollution and taking action on it, et cetera, to drive the achievement of these guidelines. Similarly, we have, because we spend 85% of our time approximately in the indoor environment, and for many people, it's very exposed with household air pollution. Sometimes almost 100 times the guideline levels of the WHO. So we're really trying to advance the clean cooking aspect as well as other clean household energy. And we've got guidelines as well as a set of tools to support the health, energy, environment, and other sectors to design and develop policy and programs that really ensure that the acceleration of clean cooking to protect health. The lack of clean cooking in homes is one of the most important sources of, for example, contributing to the severe pneumonia burden in children under 5. So these are very critical. You'll notice that I'm putting up here the SDGs and all of these, the Sustainable Development Goals. WHO is reporting as the custodial agency for the air pollution related Sustainable Development Goals and Target 3, as well as the one on clean cooking and the energy goal, as well as sustainable cities, so on the 11 goal as well. So we're really integrating to make sure that these guidelines and our work and advocacy is going to these other sectors to make sure that we can advance to clean air. And again, considering the focus of oxygen and the importance, another aspect for lack of clean, and there's not only lack of clean energy in the home that's a big risk for health, but we also want to make sure that the healthcare facilities alone have electricity. We recently did an analysis, and there's a large number of healthcare facilities that have no access to electricity or no access to reliable electricity. We estimated that it was about 1 billion people are served with healthcare facilities without reliable electricity. And without reliable electricity, we can't deliver the services that are needed to protect health. And for example, like oxygen, access to oxygen. So we're really working, trying to ensure that we as the health sector and the health community are also ready to ensure that we can deliver what we need to address those risks associated with air pollution exposure. Almost towards the end here, one couple highlights here. The importance of the primary healthcare approach, which I alluded to too. Oh, there's not one solution to air pollution. There's not a one size fits all. We need to be really working across different sectors to really manage the air quality we have in cities and in rural communities, peri-urban areas, et cetera. Whether that's transport, power generation, waste management, household energy use, buildings, there's a whole breadth. So we're really trying to ensure that we're really tackling and working with the different communities and that the health professionals are equipped to do so. We have a strategic approach in WHO, really looking at both knowledge and evidence measuring progress, the importance of institutional capacity strengthening, as well as leadership and coordination, because these are all the important pieces, puzzle pieces that are important are needed to really ensure that we have a global approach to cleaning up the air that we breathe. And as of course, our most important constituency are health professionals themselves. So we're really trying to push our health sectors to take a more active role, really integrating air pollution into strategic objectives for non-communicable diseases and communicable diseases, and training our health professionals to get there. You'd be surprised, but most medical school curricula don't even include air pollution. So we are now trying to work to provide some professional training and advocate for the inclusion of air pollution as a risk factor in health professional training, whether that's doctors, nurses, midwives, community health workers, or those public health professionals working in Ministry of Health. So WHO really is aiming to ensure that we clean up the air that we breathe to protect health now and in the future, because they can only provide win-wins for all of us, both people, the health of the people, and the planet. Thank you.
Oh, brilliant, Heather. We're recording, so we've captured that phenomenal deck. Thank you so much for sharing that. We know you may have to run, but we thank you so much for being with us, and we really applaud WHO's leadership on air pollution. The rest of the world has to catch up to you, and we hope our webinar makes a small contribution. So thank you so much for joining us.
Thank you so much. And please reach out if you have any questions or if I can provide you with any more information. And thank you again for your participation and attention.
Terrific. Okay, thank you. So say bye-bye to Heather. And we're bringing on now Dr. Laura Jane Smith. Dr. Laura Jane is a respiratory clinician, expert, advocate. She's with King's College Hospital, but she wears many hats. She's also part of the British Thoracic Society, and they have just produced this extraordinary position statement that we wanted to share with you. So Laura Jane, over to you.
Thank you very much, and thanks for the opportunity to be on this really fantastic international panel today on World Pneumonia Day. Hopefully that is sharing my slides. So as we've mentioned, so I have the good fortune to be not only a frontline clinician, but to have a role in the British Thoracic Society, and a new position was created, a board level position specifically on climate change and lung health. And that's the role I have. And as part of that role, we have written a position statement on sustainability in the environment, climate change and lung health. And I'm going to share just some highlights from that today. You can read the full statement here using this link or QR code. The reason that we thought that this position statement was needed was because the data on climate change has really moved on quite rapidly. And we hear from our respiratory community a lot that they are really worried about the effects of climate change on lung health, because we know it disproportionately affects our respiratory patients, but that they also felt ill-equipped to talk about the issue and, even more importantly, to act on the issue. So the statement kind of gives a bit of background about what climate change is, the fact that it's human activity mostly related to fossil fuel extraction and burning, but also we highlight things like animal agriculture as a huge contributor, particularly to air pollution, and also plastic waste, which is a real concern. The statement adopts the model of the Centre for Sustainable Healthcare to look at what sustainable clinical practice of the future would really look like. And so there are 4 pillars to sustainable clinical practice, and we apply these pillars to respiratory healthcare practice. So we look at prevention, patient self-care, lean service delivery, and low carbon alternatives. And I'll just mention those briefly as we go through. I think it's, oh yes, it skipped one slide there. So just to go back briefly, the reason that this is really important is because we aspire to be a leading voice in sustainable healthcare and inspire our members to take action and contribute to a healthy and just future in which everyone can thrive. And we acknowledge the fact that climate change is the greatest threat to health the world has ever faced. So it really needs to be top of our agenda in all of our work. We also acknowledge that solutions must redress current injustices, both within our own country and our own communities, but also globally. And as the previous speaker has mentioned, that we really need to think about this as fundamental human rights to access things like clean air and water, safe housing, and reliable access to healthcare, which at present are really not a given. So starting off with our first pillar of prevention, we talk about the fact that respiratory disease affects 1 in 5 people in the UK and is the 3rd largest cause of death. And we've heard from our other speakers that is even higher in other countries, particularly those with very high exposure to air pollution. We've highlighted that many respiratory diseases will worsen as the world warms further, increasing the demand for respiratory healthcare. And at present, resources allocated to prevention don't match the need or the potential for social and economic value. And so we cover a number of different areas under the banner of prevention that all will both improve the lives of our patients, but will also contribute to reducing our impact on the climate crisis. And we think about cigarettes, which have a huge direct environmental impact, deforestation, air and water pollution, as well as an estimated carbon footprint of 80 million tons of CO2 per year. And of course, that doesn't then consider all the healthcare associated with smoking-related diseases. We highlight the value of vaccination in terms of prevention of disease and of the need for healthcare. And we also do cover exposure to both indoor and outdoor air pollution and reference the WHO limits. We mentioned overdependence on cars and the problems that brings. And we also discuss vapes. So at least 1.3 million disposable vapes are discarded every week in the UK, wasting precious resources such as lithium and contaminating land and ocean with microplastics. There has been some legislation recently which will lead to a banning of disposable vapes, which is a very positive move, something that the British Thoracic Society support. We discuss antibiotic and antimicrobial resistance as a real concern for our future, and we talk about the value of physical activity, active travel to reduce disease. Thinking about patient self-care and empowerment, this is something that gets talked about a lot, but opportunities to implement this in the clinic can be difficult to find. But there are a number of ways actually that we can structure in patient self-care into our management plans for our patients living with respiratory disease. And there are alerts that are available for people for adverse weather warnings and high pollen days, as well as air quality alerts. Certainly, I recommend those to my patients in London who are living in areas of very high air pollution. Of course, the principles of our guidelines along the lines of co-created self-management plans and the importance of culturally specific resources really must be underlined. And increasingly, there is access to digital tools, but we need to be mindful that these need to be accessible to all and need to be useful rather than an additional burden for people with health conditions. And part of patient self-care and empowerment is that patients actually have access to the right information so that they can be part of the decision-making process on their own treatment. And that's particularly true when we think about inhalers, which we'll come to in a moment. But patients having that information about the different options for different inhaler devices can help them become empowered because they often tell us that they are looking for low carbon care. Lean pathways are another way that we can think about how we make our practice more sustainable. And this might be something that's not as familiar in terms of terminology, but there are many ways in which we can make sure our care is efficient and not fragmented. This improves the patient experience, reduces pathway lengths, improves safety, but also leads to cheaper and lower carbon care. So the ways that this has been implemented are things like care bundles and checklists. The surgical checklist is very famous, but there are other examples of that. Deprescribing initiatives for low-value medications and reducing overdiagnosis are very important. And then concepts such as value-based healthcare, so trying to get the most out of limited resources for the greatest patient benefit. Realigning financial incentives towards care that is not only good for patients but good for the planet is important and sometimes been overlooked. And of course, prevention leads to reduction in admissions, which is always optimal because a hospital admission is not only expensive but is a very high carbon event. Low carbon alternatives has had a lot of focus because obviously inhalers are a big part of respiratory care's contribution to the climate breakdown. And our MDI metered dose inhalers have propellants, which are hydrofluorocarbons and are very, very strong greenhouse gases. You can see here a comparison of two salbutamol inhalers, one which is a Ventolin MDI inhaler and one which is an Accuhaler. And the difference in terms of the carbon footprint is stark. So the equivalent of driving an average petrol car 175 miles versus 4 miles. So that's a big difference for the same medication. So if a patient can use a dry powder inhaler, we would always favor that. Of course, that's not the case for every patient. And so we need options that are lower carbon for our patients who are reliant on MDIs, and we look forward to those being available. There has been a shift in asthma care led by GINA to SABA-free pathways. So that's where we have patients who just have a single combined inhaler with a long-acting beta agonist and an inhaled corticosteroid. And that they use that as their single inhaler, both regularly if needed, but also as their reliever. And this means that we don't need to rely on our blue inhalers. This is a big culture shift, and so is an ongoing education task. But has a real opportunity to hugely reduce our impact from inhalers because most of our carbon footprint from inhalers is on reliever short-acting bronchodilators. So we have a huge opportunity here to not only improve care, which this approach has been proven in numerous studies to do, but also that good clinical care, as is so often the case, is good planetary care. And then we acknowledge some of the challenges, and our previous speaker talked about the lack of air pollution education in medical school. We see that throughout, actually, and not just with air pollution, but with climate crisis, climate breakdown, and the impacts on health more generally. And so there are opportunities for both for undergraduate, postgraduate, and continuing professional development to ensure that our multi-professional teams have equitable access to the right information and can then turn that into action. And so at the British Thoracic Society, we are committed to including a statement on climate change and lung health in all of our new statements and guidelines, whatever they're on, and also to create an evolving sustainable respiratory care toolkit, which is currently in development, which will be a dedicated resource to the respiratory community and will cover all aspects of sustainable respiratory care, including air pollution, but also all those other factors that I've talked about. And the aim for this is to be very actionable for on-the-ground clinicians, so to turn some of these policies into things that people can do in their local clinics, and to really be able to implement quality improvement solutions. And then we also talk about the role of healthcare professionals more broadly in the discussion of the climate crisis. Nurses, doctors, and scientists are still very trusted, and that is not the case for many other professional groups, including even civil servants down at 51%, TV news readers down at 42%, bankers 39%, and politicians down to just 9%. So there is low trust in many people in society, but nurses, doctors, and scientists are still high up there at over 75% and at 88% for nurses in this study. So we really need all our healthcare professionals to feel equipped and able to advocate for change. And so we've committed as the British Thoracic Society to support all of our members to do this and to integrate this into really day-to-day work. This needs to stop being something for enthusiasts and to be part of our day-to-day work because our future demands it. And we highlight the roles and responsibilities of different members of the respiratory community. We all have a responsibility to act with urgency, given the problems that we've laid out, and given the needs of our patients who are disproportionately vulnerable. And so we've identified some different ways in which individuals, organizations, and of course industry need to contribute to the solutions. And if everyone commits to this, then we really can accelerate the change that is needed to mitigate the worst of the problems we're going to see, even within our own lifetimes. Ooh. And I will just finish with a quote, which I think is useful to remind us. Sometimes it can be very overwhelming to think about the impacts of the climate crisis and feel that there's very little we can do as individuals, but to refuse to participate in the shaping of our future is to give it up. I think that's a really important message here from Audre Lorde, and each of us must find our work and do it. And there are opportunities for us all to make a meaningful difference in this fight. So please do read our position statement. It's a great read. It has some really, it's laid out in a way that's really accessible and has lots more information than I've been able to cover today. And also there's some additional resources and actions to take for individuals and for organizations on this other QR code, which was just a document I created for our summer meeting. So that's thinking about individual actions like divestments from certain banks, thinking about diet and active travel, but also actions to take at work today. And you can find me in many places online, but my link tree is there. Thank you for your attention today.
Thank you so much, Laura Jane, and we applaud the British Thoracic Society, if you could pass that along, for this extraordinary position statement. I mean, there are many, many societies all across the world that to deal with this area of respiratory health. We will do our best to share this as a sort of best practice example. It'd be wonderful to see other societies take a look at this, adapt it to their own settings and pump it out, because it's an extraordinary way of mobilizing a clinical workforce and broader societies, patient groups and the rest. So thank you so much for sharing that with us. Okay, wrapping up this line of stellar speakers is someone who's going to talk to you about something quite different. So the rising air pollution, climate change is driving this respiratory ill health. A lot of these patients need medical oxygen. However, you won't find many of the medical oxygen community talking about climate sensitive and energy efficient oxygen solutions. In fact, as far as we're aware, John and his team are the only ones who've taken this on in a very practical way to try and find solutions to meeting the increasing demand for oxygen that don't come at the price of contributing to climate change and fossil fuel dependence. So John, it's with special pleasure I hand over to you to unveil some of the extraordinary work you and your team are doing in West Africa.
Thank you. Should I start with sharing now? You can see. All right, are you able to see the screen okay? Leith? Let me see.
It's perfect. It's perfect, John.
Okay. Okay, great. Okay, yes, today I'm going to talk about climate sensitive and oxygen efficient oxygen delivery. And what I would like to call it is the nexus between oxygen, energy, climate, and health. They're all interconnected in a very critical way. And all of the previous speakers today have actually highlighted different aspects of how they're connected, in each of those presentations that have already been delivered today intimately relate to what I'm talking about now. I have no conflicts of interest to disclose. I work with Johns Hopkins University Global Alliance of Perioperative Professionals, which is a global health perioperative care team. We won't go over all of the things we'll cover. We'll just cover them instead. I would like to thank the funding for the African Infrastructure Support and Relief Team, which is this project is to create energy efficient, climate friendly oxygen delivery and renewable energy for different key hospitals across West Africa. This is entirely funded by direct relief through the Society of Critical Care Medicine. And so our group is simply the implementation team for that. The projects where we're currently working and which I will be using as an example are the Gambia, Sierra Leone, Liberia, and Ghana. And so we're actually in real time applying some of the things that I'll be talking about today. To give you a little bit of the landscape background, obviously everyone here, I think, understands that oxygen is quite essential, not just for us to breathe here and now, but also for us to actually, as a drug, as a therapy in the hospital. So can you imagine that up to 2022, there were no hospitals in the Gambia that had an oxygen delivery system, including the 700-bed research and teaching hospital. Major hospitals in the Gambia, as an example, can spend from 50% to 100%, especially during COVID, of their entire monthly revenue, including all money they get from the government, simply on purchasing oxygen cylinders. We're going to talk about how climate unfriendly oxygen cylinders are. Next, many hospitals have no choice but to use industrial oxygen for patient use. And diesel for generators can rival or exceed oxygen cylinder expenses in some hospitals, while other hospitals simply ration energy for certain times of the day, leaving patients at risk of death from the different conditions they may have that may need technology. We definitely work close with all of the governments in Ghana, Liberia, Sierra Leone, and the Gambia that we work with. This is one of our meetings in the Gambia. And we are interested in other technologies, not just the ones that we're applying, but here we're actually looking at different technologies in West Africa that are used for oxygen generation with our expert engineering team so that we could better understand how we can improve the current landscape, which is quite unsatisfactory. So oxygen, of course, is a drug without any alternative, and you can't create oxygen without energy. Other than the 21% oxygen we're breathing, you can't create oxygen for medical therapy without energy. And yet, if you have energy deficits, the patients actually are at risk for dying for other reasons, even beyond oxygen. This here is a ship that is anchored multiple times that I've visited Sierra Leone. I've seen this ship anchored off the coast of Sierra Leone. It is anchored off, there's other ships from the same company anchored off the coast of several other West African countries. This ship is burning crude, sending plumes of smoke up into air with electrical lines going to areas of the cities that have extremely unstable power grids. You can only imagine the detriment to the climate that this type of way of delivering electricity results in. I'm not going to play the audio on this for time reasons and also because it's difficult to hear. This is Dr. Jella, who is the recent outgoing Minister of Health of Liberia. And what she's describing is that many of her hospitals have to ration the energy. In other words, they can only leave the diesel generators on for maybe half the day. Why diesel generators? Because the grid does not go to many areas of the rural environment. So these diesel generators are just running there as long as they can. They don't have enough money to run them 24 hours a day. But all the days that they're running there, emitting plumes of pollution, as long as they can afford the energy to the diesel fuel to run them. And then when they're not running, the patients are even at greater risk. And so we have a double whammy of different risks. Here, we actually, this is another one. This is Dr. Jalla. I'm sorry, Dr. Samade, who's the Minister of Health of the Gambia. I'm going to narrate this right now rather than play the video for time's sake. But Dr. Sala is talking about recently when he was head of the surgery department at the Edward Francis Small Teaching Hospital and was down to his last half a cylinder of oxygen for a 700-bed teaching hospital. So how were they getting oxygen without any oxygen generation in the country? Much of it was being imported from Senegal. So just imagine the logistics of oxygen being produced in a PSA plant in Senegal, then compressed into cylinders, which is also energy intensive and climate unfriendly, trucked with diesel trucks all the way across the border and over into the Gambia. So this is just the building that we built for our oxygen plant, which is a different technology. It's called a VSA oxygen generator, and it uses about 30% of the energy requirements as a PSA plant, which we're going to talk about the difference between the two in just a moment. The point being is, if there's a way that uses 30% of the diesel and puts out 30% of the pollution, then why aren't we looking at this technology more? Dr. Jalla was quite frustrated with the fact that many of these new oxygen plants are being produced and placed across Africa, including her country, without any plan for how they're going to energize them. So imagine if your hospital can only provide energy for the hospital for half of the day, and then you add a PSA plant on top of that, which requires even more energy, then how is that going to work out? In addition to the amount of carbon dioxide put out by your diesel generator situation. So this is just a diagram of how oxygen is made. Most people aren't familiar with how oxygen is made, and basically it goes through a type of a membrane called zeolite, which absorbs the nitrogen. Since your air is about 70% nitrogen and 21% oxygen, then that leaves mostly oxygen left once the nitrogen is pulled out, and then the oxygen is stored in that tank. And then there's a real energy dependent process where they actually compress the oxygen into cylinders. So if you then have to truck the oxygen with diesel trucks around the country, then you use up even more. This is a demonstration of the CO2 output, the carbon dioxide output, using VSA technology, which is only uncommonly used, versus PSA technology in terms of carbon dioxide emission output. You can see it's 22. This would be assuming you were using diesel generators for your energy. So if you're using diesel generators for your energy, you're going to put out 22.4 tons versus 2 to 3 times as much carbon dioxide for most conventional oxygen generators. And that can actually result in a carbon credit reflection in terms of the money that can be recouped from the government in terms of carbon credits as well. So one of the things to consider when you're creating new oxygen generating plants, which are essential, I think we all can agree that we need more oxygen. How can we treat pneumonia and other conditions? How can we do surgery without oxygen? We need the oxygen. But we have to think about how we're going to power that oxygen. As Dr. Jalla just was talking about, which I narrated. Are we creating the oxygen through the power grid, which can often be unstable and damage the oxygen generators themselves? Are we creating the oxygen through diesel generators? Are we creating oxygen through renewable energy? Because if we think about that and we plan on renewable energy from the start, then we can eliminate all of those tons of CO2 that are produced from the generation of oxygen. And in addition to that, we can also solve the problem for the hospital itself by expanding that solar application so that it powers the hospital, therefore providing them with 24-hour stable electricity, as well as no CO2 output from energy, from producing electricity. And you can see here on line 2, 59,161 tons of CO2. This would be comparing to zero CO2 output if you were using renewable energy and, in addition to that, using an energy efficient way of making the oxygen. Of course, you can also use renewable energy even if your way of making the oxygen is not efficient, but you will need more land and more battery and more everything to provide the oxygen for that type of oxygen generators, but it can be done. So now, in terms of the vacuum swing absorption, this, again, significantly lowers the energy requirements. There is a direct correlation as to how much diesel you need to put in a generator to make electricity for this with how much CO2 is actually offloaded. And in addition to that, the interesting thing is the quality of air that's in the housing for this also has a relationship with the quality of the oxygen produced as well, and the strain on the machine as well. And that's one of the reasons why we designed our own housing building for our oxygen plant, so that we could create high quality oxygen by taking in high quality air that's coming from a clean facility. So back to the issue of trucking, think about it similar to how you think about bottled water versus tap water. You're going to have to take those heavy oxygen cylinders, if you just have a central location that's making oxygen, and then filling oxygen cylinders to be transported to different hospitals or to one hospital attached to it because there's no piping, then you will have to actually take all of those heavy oxygen cylinders, load them up on the truck, run the diesel trucks, maintain the diesel trucks, fuel the diesel trucks, take them to the locations with the oxygen, and then bring the empty cylinders back. So the whole thing is, you know, from the generation of the oxygen to transporting these cylinders is just a dirty thing in terms of the environment and the air we breathe. So we propose using best practices of converting that will actually convert your diesel dollars, the dollars you're spending on diesel energy, into healthcare dollars that you could actually spend for preventive or therapeutic care. Number one, using energy efficient technology from the beginning. Number two, think about your power source. If your power source is renewable energy, then you are starting off good. You start with an energy efficient way of making oxygen and renewable energy to power the oxygen. 3, think about internally piping the pipes, the oxygen from a location in the hospital, instead of trucking these cylinders around, and try and consolidate your major medical facilities having the the piped oxygen, and then keep spreading gradually to the littler facilities. Fortunately, smaller facilities cost much less to pipe, cost much less to produce an oxygen generating plant. And we actually call it oxygen generating system because we include the biomedical technicians who maintain it and everything like that. This is us here in September with the Society of Critical Care Medicine Direct Relief Team and the Bow Government Hospital hospital staff, biomedical technicians, and Deputy Minister of Health celebrating a successful solar project. Immediately that the solar project went on in July, there was a change in behavior in the entire hospital because now the nurses know that they can actually deliver care all night. They know that they can do surgeries without everything failing if there's a power failure. They know that they don't have to spend as much money or any money for those power areas for purchasing diesel. And they also know that they'll have a much cleaner environment to breathe. So the take-home points being energy efficient, climate-friendly oxygen generation from the beginning. You have the option of VSA technology, in renewable energy, and pipe the oxygen. Thank you. Anyone interested in supporting or participating in what we're doing, you can contact me here, and I can connect you to ways of support through our Direct Relief and Society of Critical Care Medicine team.
Brilliant, John. Thank you. And that was a really interactive slide deck. It was great seeing so many moving pieces. Thanks so much for that. Okay, we have a nice amount of time for questions, comments. We have a lot of experts on this call as well who we may want to hear from. So I'm going to ask our speakers to come back on camera, just the speakers, please. And I want to kick off with the question to Rebecca early in the chat. Rebecca, I think you had mentioned a statistic, 50%, was it of children with pneumonia in your studies? Air pollution is a risk factor for 50% of child pneumonia deaths. Can we just get that clarified? Louise Thomas, I think, wants to use that as an advocacy point.
Yeah. Thank you, Liz. Yeah, thank you, Liz. I think I want to mention that we do not have specific research studies that have really looked at the health impacts, let alone pneumonia alone. Most of them are estimates. We are actually currently doing a scoping review, again, looking at air pollution and health, and we still find that most of these studies are cross-sectional studies. So most of the information that we are able to talk about is from estimates from different organizations. So the one which I shared, we had I think the Clean the Air for the Children, a report by UNICEF that thought that about 50% of the pneumonia deaths could be attributable to air pollution. And then when you look at the Every Breath Counts scorecard that came out in 2021, it puts it at around 45%. But I want to emphasize that these really are estimates. And that's why I mentioned that we really need research to be able to to have granular data around the health impacts of air pollution, whether it's household air pollution or ambient air pollution and its effect on health in the different populations. Thank you.
That's great. We can share Clean the Air for Children, the UNICEF report. Actually, we have one of the original co-authors with us of that report. She's now working in another area. I just want to call on Bissy. You're now working in climate change and health for children. Bissy, if you don't mind just sharing some of your thoughts, reactions as an expert in this area.
Yes. Hi, Lee. Thank you so much. Hi, everyone. I've been very impressed with all of the presentations and really appreciate all of the work everyone's doing. As Leith mentioned, I shifted from focusing almost exclusively on pneumonia in childhood to climate and health. So I'm the climate and health advisor at Save the Children. And I just got back from a month-long trip in East Africa where I went to Somalia, Kenya, and attended the first inaugural Climate Change and Health African Conference in Zimbabwe. So I want to make sure, this is something that's reflected across the board. And a lot of what you said, John, was what I saw in Somalia. The costs of empowering the hospitals are upwards of $20,000 per month USD. And that's without any massive equipment, that's without taking into consideration any sort of oxygenation. And they have so many oxygen plants that have been kind of dropped there over the COVID time period that are completely non-functional. They're brand new, they look pristine, but they're completely non-functional for whatever reason it may be. A lot of which is the lack of the energy. They don't have enough to be able to power the enough electricity to keep them running, let alone all of the maintenance and repair costs that they need. So this is a huge deficit. And I think that a lot of people think that because there has been a ramp up in oxygenation and oxygen plant engagement in sub-Saharan Africa over the COVID period, that this is a problem that's no longer there. And that's the exact opposite situation. What we've seen through COVID is a lot of oxygen plants put in places where there's no capacity to keep them running. I engaged with the Minister of Health of Liberia a while back, and she was telling me she had 14 oxygen plants that were funded during the COVID period, and within 2 years, not a single one of them functions. So this isn't a problem that has been solved. In fact, it's been exacerbated because we think the solution has been put in place. So I'm really very encouraged by the work everyone is doing, and I wanted to make sure that you know that this is a huge priority for Save the Children as well.
Brilliant, Bessie. Thank you for that feedback as well. John's nodding. He knows the story. Let's make sure we have some opportunity for other people to come in. So anyone would like to ask a question of our speakers or has a comment, you don't need to raise your hand on our calls. You can just come off mute and start talking.
Can
Hi,
I
Lee.
just, okay, go ahead.
Go ahead, Louise. Go, Louise.
Hi.
And just introduce yourself to everyone as well, please, Louise.
Cool. Hi, Lee. And everybody. I won't come on camera because I'm just walking down the street, I'm afraid, to my daughter's school. But yeah, I mean, all the presentations were excellent. And I think I would just really encourage everybody in this space to be really talking about it as mainstream. So it's a mainstream health issue. It's a mainstream economic issue, as I mentioned in the chat, and just I mean the numbers stand for themselves. Just make it as kind of normal that we should be acting on this, and throwing all the resources that we've got to tackle it. That would be my main suggestion. And yeah, Leith has properly introduced me, Louise Thomas from Aeroware Labs. Good to be on the call. Thanks.
Thanks for joining, Louise. Others, John, did you want to say something?
Oh, I just wanted to make one small comment to her statement about oxygen and energy plans. We took a team, including the previous Minister of Health, last year to the United Nations Climate Summit in Nairobi, Kenya. And after we gave a workshop where we actually went through a lot of what I presented, we were actually invited to visit a hospital on the outskirts of Kenya, of Nairobi, where it was a private hospital where they had actually purchased an oxygen plant from Turkey. And so because he was spending so much money on cylinders, but once he started using the oxygen plant, he quickly realized that it cost him more for diesel fuel to provide electricity for the oxygen plant than he was spending on cylinders previously. So the oxygen plant had been turned off for 2 entire years. And so we actually connected him to our renewable energy team to look at a targeted solution, not necessarily for his whole hospital, but a targeted solution for providing renewable energy specifically for his oxygen plant, so he could actually use the resources that he himself as a private entrepreneur had invested in.
Thanks, John. And thanks, Carrie from Path, who's dropped in the chat. WHO, as many of you will know, has taken on this issue of oxygen access in a big way. They're working with a lot of member states to develop national oxygen roadmaps, which hopefully would then be financed. But to John's point, I don't think many of them deal with this issue of an energy plan or look at the climate impact of the solution. So we're going to have to take another look at all of that just to make sure that these plans aren't developed totally in isolation from their energy implications, as well as choosing the most climate sensitive solutions. And John, your research is going to help inform that process. So we need to bring you into some of those conversations, John, with WHO, but thank you. Other questions, comments, viewpoints? I would just remind everyone that unlike most areas of pneumonia, we do not have a robust prevention, diagnosis, and treatment landscape when it comes to climate change and air pollution specifically. So this is in my view, I've worked in pneumonia for a very long time. This is the weakest part of pneumonia control. is preventing, diagnosing and treating anything related to air pollution, climate change related deaths. And this is the leading risk factor for pneumonia death across all ages. So that is really an indictment of all of those of us who work in pneumonia control, that we just haven't been able to build a robust set of preventive strategies, diagnostic, and the treatment side is oxygen, but as you can see, there's huge problems with it. So this is an area where we really hope we can, as a pneumonia community, we can get our act together and get much more smart and sophisticated about how to prevent, first of all, prevent these air pollution related pneumonia deaths, but also have better ways of diagnosing and treating. But let's have some more people come in. Varun, you've commented there. Did you want to make a comment? You put a link in the chat as well. Varun Manhas from One Health Trust.
Hi, everyone. So I was just going to reiterate the point that was just made by one of the speakers, that if you run PSA plants on diesel generator, they'll be the most expensive source for a hospital. But if you run a PSA plant with the power source as electricity, then it's the cheapest source of oxygen for any hospital, almost 2 times cheaper than LMO and almost 2.5 or 3 times cheaper than gaseous cylinder. So I've just shared a paper as well. We've done a study, detailed study in India, which compares the running cost of various types of oxygen sources in a hospital in India. I'm sure the results are going to be very similar to anywhere else in the world. And also to reiterate, PSA plants are very sensitive equipment. If you leave them in shutdown position for over 2 months, then they're as good as gone. So they're defunct after that. So even if at all the demand of oxygen is low, so all the people have to ensure, or the hospital administration has to ensure, that they run at least once every 2 months for 6 hours. And then you can again shut them down and leave them in idle situation or in idle condition for 2 months. And again, after 2 months, you need to run them, because if you don't do that, the piezo, the zeolites, which are the adsorbents in the PSA plants, they get damaged, and they're probably the 70% of the cost of the PSA plant itself. So that is why most of the PSA plants right now in the world are not being used, because people were not aware about, like having them sort of, one has to switch them on once every 2 months for about 6 hours. So you can sort of clear up the system. So those are the comments from mine. Thank you. Over to you, Leith.
Brilliant, Varun. Always add value to these conversations. Thank you very much. Carrie, did you just want to voice over that link you put in the chat so people know to join that important series from WHO? Carrie? We can't hear you. Maybe there's a connection issue. But this is a link to a new webinar series that WHO is leading. So if you click there, everyone is welcome to join these. There's 2 before the end of this year, and there'll be more in the new year. So John, this is where you want some of your people on these calls, just to reinforce this issue of the energy impact of these oxygen roadmaps. Are people thinking about it, and how should they be thinking about it? Great.
Is the link that says Zoom webinar or WHO Zoom webinar?
That's the one.
Okay.
Yeah. And we have a comment from Anka Sudin. Do you want to come and voice that over?
Thanks, Leith. So this is to the question earlier in the conversation around 50% of child pneumonia deaths attributable to air pollution. I think I've seen similar numbers while doing our own pneumonia work in India. And we were referring to the global burden of disease estimates on childhood pneumonia factors. The 50% though includes household air pollution, which is usually higher where solid fuels are used, while in other places, there's ambient air pollution. So yeah, just echoing that 50% seems to be the current estimate. And yeah, there's a double whammy here. We are moving to cleaner fuels, but we are, at least where I live in India, we are moving to worse ambient air. So children do not have it easy.
Good points. And the big problem with household air pollution is, despite all of these efforts, and a lot of money has been spent to try and get a cook stove or clean cooking technologies in the home that reduce the exposure, none of that has worked. So our best RCTs that have looked at that have not been able to find a cooking method clean enough to deliver a better health outcome for women and children. So the whole household air pollution space is also, I think, challenged. So we really have to focus on this area and get our act together. We have a time for one more question or comment before we start to wrap up.
I've just shared a link in the chat to a letter to the BMJ we wrote, just picking up on what you were talking about in terms of if we don't diagnose air pollution as a major cause of many diseases, but particularly pneumonia, then actually it's not visible, and that means that there's a real problem with trying to get policy change and action on air pollution. So I think that is common across countries, that actually not capturing air pollution as a health problem means that it's not visible. It's seen as separate, seen as an environmental issue too often. And so the policy at government level is not joined up.
Oh, that's great. Let's take a look at that. That's a letter to the...
It's just a letter to the British Medical Journal. We asked some, I and some other people asked coroners when they would think about having air pollution included on a death certificate, so that it would then feature in our national data sets. And we didn't get very good responses back. So there's a real gap there in terms of knowledge and education.
But we can all try that strategy with mass letters to the...
Absolutely.
Yeah, brilliant. Okay, another great advocacy tool from the BTS. Okay, so I'm going to wrap up now. We've got 5 minutes left, but I want to thank our speakers. This was fantastic. The decks were so great, and I'm sure everybody learned something. We've recorded it, so we always make our recordings available on our YouTube channel. And we'll share that with everyone who's been in attendance here. We will get an email. You'll get an email from me with the links. But today is World Pneumonia Day. It's also, as I said at the outset, day 2 of COP29. So we want everyone to go to their preferred social media platform, whatever it is, and share something you learned or something that struck you today using hashtag World Pneumonia Day, hashtag COP29. These are the 2 hashtags. We're trying to knit them together today. So both communities join forces. For too long, the health community there's been a chasm between those of us who work on public health and those others who worked on climate change, environmental health, as we used to call it. So we have to stop that. We have to sort of come together. So let's try and showcase today as a day when we do come together. I want to encourage you all to pay more attention to air pollution and climate change. We as an Every Breath Counts coalition have not done enough, frankly, to focus on this area, and we pledge today to do much more. Because when we look at the data and the trends, this is where the pressure is coming when it comes to pneumonia and respiratory. It's coming from, frankly, outdoor air pollution amongst adults, actually. And we're going to have a huge burden of chronic disease as well as infectious if we don't get our handle on this problem now. So I want to thank our speakers for joining us on what's a very, very busy day. I think Rebecca Nantanda is in 20 places over the next few days. So thank you, Rebecca, for making your time and expertise available. And to John and to Laura Jane and to Heather. Many of our speakers do have X accounts. So at Dr. LJ, right? You might want to drop it into the chat, Laura Jane. It's a fantastic one. Rebecca is R Nantanda. Heather has one at Adair Rohani H. You can find them on X, and you should. It's a great way to have a conversation. Okay, thank you, everyone. We wish you a successful World Pneumonia Day, successful COP29, and more power to all of us trying to work on public health and to improve particularly the health of the future generations of children. Thanks very much.
All right, thank you.
Thank you.
Thanks, John. Thanks, Rebecca. Thanks, Laura Jane.